welcome everyone. My name is Ian Harris and I'm going to be starting the meeting off and then hand over to others. Thank you very much for joining us. Many of you will know that we have run HIPFest for several years now, and they've always been live events, and it's only been recent COVID changes that have led us to this, but we think that this is still quite a good format. And instead of running it all day, we've made it a little bit more suitable to an online format by keeping it to about 2.5 hours, so we can do the whole lot in one session without having coffee breaks or lunch breaks. So as people are turning up, I'll go through and welcome everyone. And I want to start off with an acknowledgement of country. And I know that we're meeting really across the whole of the country. So I acknowledge the traditional custodians of country throughout Australia and recognise their continuing connection to land, waters and community. I pay my respects to them and their cultures and to elders both past and present. One note is that we will be recording this, and this is so people who have missed out can look at it in the future, and people who want to look at it again can do so. So by continuing to be in the meeting, you're consenting to be recorded. So now I'm going to take you to the first panel, and I'm going to be chairing the first panel. And this is a panel on anticoagulation, and I actually volunteered to chair this so that I didn't have to be in the panel. And because I'm very interested in this, so I'm an orthopaedic surgeon, I treat lots of hip fracture patients, and I am constantly confused by what to do about anticoagulation. And I take advice from my colleagues, other surgeons, from geriatricians, haematologists and anaesthetists, and quite often I get different advice. So we thought we'd get them all into a room together, and I'd ask the questions and they'd answer them. So introducing the panel, and hopefully you can see them and they're going to be unmuted, is going to be, the first one is Chris Jones. Is Chris there? Because I can't see everybody. Yep, okay.
Hi Ian, thanks for the invite.
Thanks, Chris. So Chris is an orthopaedic surgeon from WA, who's a highly trained surgeon who does joint replacement and trauma, and certainly has a lot of experience doing hip fractures, and also has a particular interest in how to manage anticoagulants for these patients. Also from WA, we have next to each other in the same picture on your screen is Hannah Seymour and Stephanie Ping, and they are respectively a geriatrician and haematologist, also from WA. So the first three people are all very close to each other there around Fiona Stanley in Perth. And fourth, we've got Sean McManus, who has joined us from Queensland, and Sean is our anaesthetist panel member to give us the viewpoint of the anaesthetist. So thank you all for joining the panel, and I'm going to go to the first case. And this is just going to be a case-led discussion. I'm going to just show you your typical kind of cases, and I've raised some questions about how we manage each of these patients. So this is the case for discussion. So I picked a fairly typical case. I mean, the average age of our patients is around 82. Most of them are female. They normally come in with a fall from a standing height. So there's nothing unusual here. This patient's not from a nursing home. They're from home. They're a community ambulator. They use a walking stick, but otherwise quite independent. And like a lot of our patients, they're on a long-term DOAC, they're on long-term direct oral anticoagulant for various reasons. This one I've just chose atrial fibrillation. And they've got a displaced intertrochanteric fracture. Now, this is important because for this operation, the surgeon is going to do a percutaneous intramedullary nail. So it's not a highly invasive procedure that they're doing. So that's the setup. We'll change some of these variables for the discussion later, but that's where we are at the moment. So I'd like to throw it to the panel and firstly ask a fairly simple question. Do we need to stop this drug to have this surgery? Sort of yes or no. Who wants to take that first?
I'll go first if you like, Ian, and then Steph's going to join in, and Chris, I'm sure, will join in, and then we can throw the curly questions to Sean about
Okay.
the final. So part of what you discussed at the beginning, Ian, was the frustration you have with varying advice. And the reason that the three of us are here is that we have agreed a local protocol. So we do at least have something written down that we attempt to do with DOACs, where we agreed something early on in the absence of guidelines, because I think it's important to recognise that there haven't been any really good international guidelines on what to do in this situation. And we started off with lots of people suddenly being put on DOACs and not really a good plan. So we developed a local plan, which we've audited but not published. So we'll talk about some of our local experience, but we haven't published it. I don't know anyone who wouldn't stop the DOAC, at least perioperatively. And the bridge trial, I think, gave us confidence that for atrial fibrillation, we would routinely stop it quite comfortably, a DOAC for 4 or 5 days without stressing too much about it, and just give Clexane instead. But the big question is how long to wait for surgery. And there is some patient-specific things that you need to think about in that regard. This lady will almost certainly be in a lot of pain. She's got a nasty intertrochanteric fracture. They hurt. And I think that's important to bear in mind. Compared to, say, a subcapital fracture, which might be slightly different. So the evidence is different we're doing different things in different countries. In the UK, they are pretty much cracking on at 24 hours post last dose now. I don't think many people in Australia are doing that, but we'll see. So here we measure levels, and we've got a system set up. We work in a tertiary hospital. We have good access to the lab. And we routinely measure levels at 6 a.m, have them back for our morning meeting and decide whether to proceed. But I might let Steph add to that.
So when the DOACs first came on board, people didn't really know how to use them in a perioperative setting. So I guess in the first instance, we decided to do levels. Most of the perioperative guidelines for other surgeries now tend to suggest you don't need to do levels. And I think that's mostly because of a lot of the literature comes from the US, and a lot of the centres can't do levels. So for the insurance purposes and the payment of it and the litigative kind of protection, they have said from their guidelines point of view that you don't necessarily need to do a level pre-operatively. We decided right at the beginning of this process to do it just to make sure that we had a bit of an idea and kind of it actually accelerated our, I guess, experience and our kind of comfort level with using these anticoagulants. And actually, probably most of them will clear within the first 24 hours, which is kind of gives us confidence and supports that concept of maybe just stop at 24 hours beforehand. The official, I guess, hematological guidelines for Australia say for a perioperative situation, it's usually a good 2 days, unless it's high-risk bleeding, in which case you might have to think about 3 days. And then, of course, then you have to think about also the high-risk bleeding, sort of low-risk clotting situation.
Chris, anything to add before we throw to Sean?
Yeah, thanks, Ian. Look, I echo your frustrations of advice and receiving different advice when the same question is asked within the same service. The problem with asking for advice is you're then duty bound to follow it. So that makes it a problem. That's something that we don't have an issue with at Fiona Stanley in our shop, because everyone gets on so well and we have these protocols in place. The next issue is, why are we stopping the anticoagulation? So most of the bleedings probably happened as a result of the metaphyseal nature of this intertrochanteric fracture. So the blood loss for the patient has largely been after the fracture and the displacement of that fracture and the bleeding that's occurred there. Intraoperative bleeding should be relatively minimal, particularly with a percutaneous approach, which is probably why you chose that case. So most surgeons are going to be pretty happy to crack on, relatively speaking. Hematomas can, of course, occur, and that's of concern. one of the major reasons why we want the DOAC levels to be at an appropriate level is so that our anaesthetic colleagues feel comfortable providing the patient with a spinal anaesthetic. And because we know that in our series, the neck of femur fractures do so much better with spinal anaesthetic in terms of their post-operative management on the ward and delirium and so on and so forth. So I think that those factors all come into play and really need to be discussed in this setting. And then my own personal bugbear is if these patients are falling over, should they be on DOACs in the first place? And we have patients coming in with multiple fractures, like we're doing, they're NOF and then they go back on a DOAC and then they come back in, they've broken their shoulder, they go back on it again, they come back in. So at what point do we need to consider the risk of maintaining the anticoagulation? But that's a whole separate discussion.
Right, and Sean, do you want to give?
Thanks, Ian. Look, it's interesting that I think we touched on that with the previous speaker about the fixation about whether you need to do a spinal or a general anaesthetic, and that's clearly the major interest of the anaesthetist. It is interesting that there are differing opinions about how much difference a regional technique does make to outcomes, because that's up for discussion. We can talk about that. But the short answer is that most of us would be happy to wait 24 hours here in somebody who's got relatively normal renal function, and that's an eGFR of over 60. If it's less than 60, we might be a little bit more concerned. And I would say the vast majority of us don't have the luxury of being able to do anti-XA levels. So we would just think 24 hours is reasonable. I also do think that a lot of anaesthetists are now understanding that waiting is not a benign intervention. So if this was not a hip fracture and it was somebody who needed an operation, we might be waiting a little bit longer. But I think anaesthetists are acknowledging that hip fracture patients are a unique cohort, and we need to be mindful that it's a balanced approach as to how long you wait.
Thanks. Well, there's some good points there. I'm hearing a lot of 24 hours in those answers, which is a lot shorter than was certainly the original advice when we started getting these patients, where we were waiting for a few days. And there's been a question on Slido, a few people have asked about the role of renal function and how that impacts. But I think you've answered that. I think you said 24 hours is fine, provided renal function is normal. And if it isn't, then that changes things. Okay, so thanks for that. And so talking about the levels, some hospitals do, some hospitals don't. We've put a Slido question in there. So if you go to the Slido polls, I'd like you all to vote if you don't mind, because we want to get some idea of how many of you out there assess these levels and how many don't. Speaking for me, at two different hospitals that I work, we don't do them routinely. And looking at the response there, it looks like we're around about the 80% mark of people who don't routinely do these levels. So they're going to be using your other kind of advice, which is, somewhere around 24 hours, as long as the renal function is okay. All right. And we've got another question, though, for the people that that do use the levels. At what level do you proceed to surgery? And so if you go back to the Slido, yeah, you have to put in a response to see the answers, so I'm not sure.
While that's coming, I might just make a few comments. So I think for 24, we didn't talk about what dose of drugs, which DOAC and which dose. Yeah. Yeah. So there's a lot more people on low dose DOACs now. A lot of
people, it's working.
Thank you. Around age or looking at patients who are quite reducing.
Thank you. Thanks so much.
Warfarin's joining us, and we need to mute them. Or they need to mute.
Oh, we need to mute it.
So I think there's a lot more people on low dose DOACs, and they clear quite quickly. And so again, that provides a lot more reassurance. So the dose of DOAC is important, and I'm not sure that all the orthopaedic teams are aware of that. And there's a lot of people on lower dose DOACs. Most people are now on apixaban, I think that's the same across Australia, which is twice a day. So again, that makes a difference, because if you're giving a low dose twice a day, you're going to clear it much more quickly. So I think our data here supports going ahead at 24 hours. And I think that's a really good question. And it might be useful to add a poll asking about how long people wait if they're not doing levels. Because if 80% of people aren't doing levels, it'd be really interesting to know, A, if they have a local guideline about how long they wait, and do they wait 24, 36 or 48 hours?
I think a lot of them, we can probably prepare that question and ask that at the end. And but I think a lot of people are tuning in because they want to know, a bit like me. So I'll go back to the presentation. We now go to change it up a little bit. So that discussion was more around the DOACs. And my next question is, what if this patient was on warfarin? Do you need to stop it? If you do, what INR levels are you looking at to be compatible with surgery? And what INR level is compatible with anaesthetic? So I might change it around a bit. I might start off with Chris this time to get his opinion on how comfortable he is operating at certain INR levels.
Yeah, much more comfortable operating on warfarin with an elevated level than I am on heparin or clexane and or therapeutic clexane and or the DOACs. Warfarin bleeding seems to be different to the other sorts of bleeding. It's a subjective thing that you see as a surgeon. So for me, anything INR 1.5 or less, ready to go. And pretty aggressive in terms of our reversal protocols, either in both the elective surgical setting and also in the trauma setting with neck and femur fractures. So prothrombin X or vitamin K. Certainly in the elective setting, where we're usually seeing warfarin on patients with historical mechanical valves, prothrombin X immediately prior to the surgery, and then recommence the warfarin thereafter. This is the area that we see the most variation in the advice. It's usually a good registrar who won't tell you that they've asked cardiology or hematology for advice, and then you get these wildly varying bridging plans, which is different depending on whether you ask the registrar or the consultant. So again, that's where we will maybe just, within our own arthroplasty unit, we are developing our own protocol so that we are standardized in our use of prothrombin X. That's occurring at the moment. But certainly for neck and femur fractures, vitamin K or prothrombin X and bat on, get it done.
Okay, so reverse, and you're pretty comfortable at around 1.5. I might throw it to Sean, particularly regarding the spinal anaesthetic and INR.
Thanks. Yeah, I agree with Chris. I mean, clearly with this sort of stuff, it's a 2-by-2 table, as in, the need for the warfarin, mechanical valve is completely different to somebody in AF versus the risk of bleeding in surgery. As far as spinal is concerned, we're happy at 1.5. You don't need to correct it for more than 1.5. So we're on the same view, same page as the surgeons for that. And again, I would agree. We're much less anxious about warfarin as an anaesthetist than we are about the DOACs and clexane.
Okay, good. So good concurrence between the anaesthetists and surgeons.
Ian, you would have seen this, I'm sure, with your extensive history. The bleeding, surgical bleeding that you encounter with warfarin patients, they just don't seem to ooze from all the tissue planes and have that constant, as long as you're careful with your hemostasis and no large vessels are injured, they just seem to behave pretty normally. And most of us, rue the day the DOACs were ever invented.
I must admit that my threshold for warfarin is that, particularly if we're doing the percutaneous approach, which is what we're doing here, is that we tend not to worry about it much at all, and we'll accept an INR up to 2.
And Sean, I'd like to be clear, I'd be happy with an INR 2 if we weren't doing a spinal. So once again, if you're not fixated on spinals, that's another discussion. We just crack on with the GA with an INR of 2 if you were happy as a surgeon.
Ian, it's Hannah. I might just give a contrary view to Chris around DOACs. Although they've been a large inconvenience to us in our approach to hip fractures for a short period of time, and I'm sure as with antiplatelets, we'll get to a consensus pretty quickly. They are overall a very good thing for older people and stopping them having strokes. And the evidence is that geriatricians are probably too cautious about stopping DOACs and stop them too often, and we're harming people by doing that. So I'm just going to put the contrary route to remind us that we do need to have balance.
Anna, do you think, on that note, is there an increased incidence of therapeutic anticoagulation in the elderly population now that they don't have to have weekly INRs?
So yeah, I think we've got data on that. So about 12% of people are now on anticoagulation in a hip fracture population.
Wow.
And that's exactly
yeah.
the group of patients who have AF.
Yeah.
And overall, when you look at the really big registry studies in Denmark, for example, they are much safer than warfarin in terms of bleeding risk. And overall, they are stopping harm to people. Having said that, we do stop. So we do stop quite a few people's anticoagulation, people with severe dementia in a nursing home. It's definitely the role of the geriatrician within the acute service to do that. But I think we just need to remember balance.
But so that's interesting. That wasn't actually my question. The question was, do we know whether more people are anticoagulated now because it's easier?
I don't know whether or not we know that more people are anticoagulated. I think back in warfarin, when warfarin was the majority of the anticoagulation use, there was definitely by far the highest medication-associated complications for hospitals. I'm not exactly sure because I haven't seen it very recently, but I think that percentage has gone down a little bit in terms of overall complications associated with medication. And probably by far the majority of people on anticoagulation are on DOACs now. And maybe that reflects better control, but it probably reflects also the fact that you can have a bit of variation in the dosage of the DOACs for the different indications.
I might direct people to Slido again, because we've put we were just about to put the question up that Hannah was asking. Yeah. So if you don't do DOAC levels, we want to just poll the audience to find out how long they wait, 12, 24, 36, 48 hours, that kind of thing. Because we've been hearing that the 24 hours is okay if renal function is good. So by polling people, though, we're seeing that 48 hours is very common, with about half of respondents giving us a 48 hours and the next most common being 24. I think that makes sense to me, because I think a lot of people out there are probably a little bit more cautious than this panel, which is more sort of cutting edge, latest evidence stuff. And I think out there in the community, people are being asked to wait 2 days or more when they don't have the levels.
But Ian, I think that's where we can maybe help by writing some sort of consensus standard for Australia. And I think our levels studies show us that probably 24 hours from admission or 36 hours from last dose is definitely, that's what our data says. And remember, it depends when you start. A lot of people will have taken their medication in the morning and then come in the afternoon. But again, a Pixabam you can probably be a bit more aggressive with. We've aggressively done levels, and that has brought us way less than 48 hours, and we've shown no problems at all. So I think we can probably start writing some guidelines, some consensus guidelines that give people a bit more comfort.
That would be great. All right, so I'm going to get back to the presentation. We're going to go on, change it a little bit. Dual antiplatelet therapy. So we're not talking about DOACs with patients not on warfarin, but they've had a cardiac stent and they've been put on dual antiplatelet therapy. This time I might start with Sean, if that's okay, about your thoughts around surgery for patients on dual antiplatelet therapy.
Yeah, thanks, Ian. So, yeah, obviously, dual antiplatelet therapy, we would be cautious, and particularly those colleagues who are very keen on a spinal anaesthetic, you would be keen to stop. But once again, it's a very similar story. You probably remember 10 years ago when clopidogrel first came out, everybody said we had to stop for a week, and now it's down to a couple of days. So I think aspirin probably would be comfortable to continue with a GA. Clopidogrel, I think we would stop for at least 2 to 3 days, depending on the indication of what it's for. As you know, it all depends on how old the stent is and whether it's epithelialized. So there's lots of subtleties there, but yes, we are cautious about dual antiplatelet therapy is the short answer.
Okay. Hannah and Stephanie?
So we looked at this a while ago, and these were the patients who actually bled the most. The good thing is that less and less people are on dual antiplatelet therapy, as the cardiologists have got tighter and tighter about the guidelines for dual antiplatelets. I think it's worth adding that all of these decisions are risk-benefit. So we have had people on dual antiplatelets where we had a multidisciplinary meeting with the anaesthetist, myself, the patient, their family, and in people who really need a spinal for respiratory disease or whatever the indication is, and a really high risk, we make a shared decision with the patient about risk benefit, and we have gone ahead and done spinals in that situation. So I think you can justify any decision if you have considered risk and benefit and you've done it in partnership with the patient and the team.
Chris?
Yeah, echo those thoughts. The main times that I've seen with my patients where they run into problems is when they've also had dual antiplatelets and then they've had Clexane maybe at a high, at a higher dose if they're very low weight and they have poor renal function, and then they get 40 of Clexane on the night of their surgery. Those are the ones who seem to then develop the hematoma. So I've seen it as a post-operative issue as opposed to really varying my treatment intraoperatively. But yeah, echo the previous speakers.
Okay, and now I'm going to move on because we're going okay for time. But I want to touch on this, and I might start with Chris on this one. What we were talking about before is an intramedullary nail, where it's normally done through a pretty small incision or a couple of small incisions. Bleeding is not a big deal for it. But now, what if the patient needs an arthroplasty, like a total hip? We're now converting that little incision to a very large incision with a lot of deep dissection, reaming, and the blood loss is significantly higher. Does this influence some of the things that we've been talking about, INRs, waiting times, things like that?
Yeah. This is particularly relevant. In our shop, we just did a latest audit, and we had a look at our patterns of the devices, and we're going up in arthroplasty, and we're definitely going up in total hip replacement for this patient population. And that's a consistent theme and trend in all of our audits over the last 2 years. And maybe that's because we're staffed by arthroplasty and trauma surgeons who are dual trained, so we're more aggressive with arthroplasty. I think, to answer your question, once we follow the guidelines and our anaesthetists are happy to proceed, we'll proceed. The one thing I'll do in the higher risk patients is the consultants tend to hang on to those cases, and it's either a very senior registrar or a fellow doing the case, or more likely the consultant. These are not the patients you want to have on the table for 2 hours. You want to get a nice 45-minute hip replacement in and out, done nice and clean, and that's the way to do them. So there's subtleties in the management. Certainly not doing a hemi at 9 o'clock with a junior registrar, that's for sure.
Sean, does it make a difference to any of your decisions if they're going to have a much bigger operation?
Oh, I mean, yeah, clearly, as Chris said, the blood loss is an issue. But really, I mean, we would defer to our clearly well-informed surgeons about it. So it doesn't really change whether we do a spinal or a GA, to be honest with you. And once again, the stopping would be the same, really, from our point of view. I guess we would be very cautious if the surgeon thought he was going to do a hip replacement and sort of wasn't that concerned about blood loss, but clearly Chris has taken that into account.
And I might, just in the interest of time, because we're running a little late, Hannah and Stephanie, I might get you to answer the next one, which is, how soon post-op can we recommence it? I know surgeons are always, a bit concerned about not starting anticoagulants too soon. But what are your thoughts?
So our practice here, if you're on anticoagulation for AF, valves are different.
Yeah.
We would normally give normal dose prophylactic clexane while you're off anticoagulation, and we normally restart at 72 hours to try and give people a few days to stop bleeding and stop oozing before we restart. That's our normal approach.
And that'd be the sort of thing that we would advise for most surgery anyway, to be honest. So
Right.
8 to 12 hours post-op, they have clexane, and then if the surgeons are happy, 3 days later, they can increase to therapeutic dose.
So I guess the thinking is, as long as you've got them covered with prophylactic clexane, there's not like a super urgency to get them back on whatever it is they were on before.
No, and Ian, I think it's become normal practice to start anticoagulation too early, in my view. I think, again, people overestimate in their heads the risk of something happening in the short period of time that people are not anticoagulated. Based on the evidence, 72 hours is what the guidelines say, and yet we're often pushing that earlier and earlier. And then we cause more problems because people start bleeding, and then you end up with them off anticoagulation for longer. So we've had very, very few problems with bleeding by delaying till 72 hours.
Okay. And just because we've only got a minute or two to go, there has been a comment where somebody has said that a consensus statement on anticoagulation coming from the registry would be a good idea. I think we'd all agree with that. And on Slido, I'm looking at the questions. We've answered the one about renal function impacting DOAC stopping times. The top question is, who makes the decision on timing? Is it the surgeon or the anaesthetist? I think probably it's everyone.
I think the important thing, Ian, is agreeing something local, because you shouldn't be varying depending on who's on. You should agree a local protocol, and whatever it is, you should stick to it.
Yeah. Yeah.
I think it's a
on
shared decision. It's a definite shared decision. Sorry, Sean, to interrupt. We manage these patients as a team, and all three voices are equal in the discussion. Sorry, 4: anaesthetist, orthogeriatrician, surgeon, and most importantly, patient.
Yeah, I agree with that. Yeah.
And there's another, if you look in the Slido or you look in the chat, that the Association of Anaesthetists in the UK have published a guideline 2020, so that's fairly recent.
Yeah.
And there's some pragmatic recommendations on DOACs, and the link has been pasted in the chat. So thank you very much, Pathy, for putting that in there. So that takes us up to time, right on the dot. So I want to get back to my presentation here. Okay, so I want to thank the panel members for giving up their time and giving us their expertise. It's helped me personally a lot, so I think it's helped our nearly 200 participants who are watching.